Welcome to Brain Tumor Talk, a podcast brought to you by the Ivy Brain Tumor Center at Barrow Neurological Institute. This show unites leading experts, inspiring survivors, and compassionate caregivers in conversations about the latest in research and treatment. Together, we share stories filled with challenges and hope. I am your host, Michelle Palacino, a member of the Ivy Center team. My deep understanding of brain cancer comes from both my professional insights and personal experience as the daughter of a brain cancer patient. Brain Tumor Talk is your invitation to connect, learn, and find support in this community. The information shared on this podcast is for educational and informational purposes only. Nothing stated on this podcast should be considered medical advice. Welcome to the first episode of Brain Tumor Talk. I'm your host, Michelle Palacino. We're thrilled to launch our series with a truly distinguished guest, Dr. Nader Sanai. He is a world-renowned neurosurgeon, the director of the Ivy Brain Tumor Center, and chief neurosurgical oncologist, or the chief of neurosurgical oncology at Barrow Neurological Institute. Dr. Sanai, it's an honor to have you with us today. In this episode, we aim to provide listeners with a foundational understanding of brain tumors and the essentials of what patients and caregivers need to know about this disease. Dr. Sanai, thank you so much for being here with us today.
Thanks for having me, Michelle.
So just to dive right in, this podcast, like I said, is about giving patients and caregivers the essentials of what a brain tumor diagnosis looks like. When you get this diagnosis, it's a rabbit hole of complexities, right? But just to kind of start off, what is a brain tumor and what are the different types of brain tumors found in the body?
Right. So brain tumors encompass a whole assortment of diagnoses. In general, these are masses that we identify in the brain. The masses categorize into two subcategories, what we call primary brain tumors, which are tumors that are arising from the tissue of the brain or the lining of the brain, or secondary brain tumors, which are tumors that are traveling to the brain from somewhere else. So a colloquial term for secondary brain tumors are metastatic brain tumors. Primary brain tumors can come in all sorts of varieties. They can be less aggressive or more. Metastatic brain tumors are the product of an aggressive disease.
Mm-hmm. And so when you're having that initial conversation with patients and caregivers, when we were going through this diagnosis ourselves, we had a physician that one time approached us and was like, brain tumors are like real estate. It's all about location. So can you talk about how the symptoms of a brain tumor vary on location and then what symptoms there are associated with brain tumors?
Right. I mean, that's not a bad way to put it. So the brain itself is regionalized and there's different functions in different regions. So depending on where the tumor is located, that'll dictate what kind of symptoms you're going to see. The skull itself is fixed in volume. So no matter where a tumor is, it's occupying space that your brain is not designed to accommodate. And so you can have overlapping symptoms simply by what we call mass effect, which is just the space occupying nature of the tumor. The brain itself, we can subdivide sort of very generally into these anatomic regions: frontal lobe, temporal lobe, parietal lobe, cerebellum, brainstem, and then there's a left or a right. For most patients, there's a laterality to their brain, meaning if you're a right-handed person, almost always language function, which you develop early in life, is localized to the left hemisphere. So for some patients, a left frontal tumor could give them significant language deficits, but a right frontal tumor may not give them any symptoms at all, or perhaps a headache. Similarly, if you have a tumor located in the cerebellum, which is the back of your brain, that's where a lot of coordination type efforts are relayed through your brain. And so patients may present with difficulty with balance or coordination issues with their arms or legs. So location matters a lot in terms of how patients present. And then, of course, it matters a lot because when you're treating the tumor, there's often collateral damage to the areas around it. And so if those areas are really sensitive, then the risks are higher.
So we have a lot of patients that come to the Ivy Brain Tumor Center saying that their brain tumor is inoperable, right? And then you hear these victory stories about how you're able to operate in these sensitive areas or you're able to get an inoperable tumor. Can you talk about what makes a brain tumor inoperable?
Yeah, so the term inoperable is a pretty dramatic term. You know, it implies that there's just no possibility of removing something. And the fact is that in neurosurgery today, surgeons are so adept at the technical aspects of neurosurgery that there are few areas that are truly inoperable. The question is not so much, can you remove it? It's should you remove it? And so that question is often colored by what you expect the consequences of surgery to be. So I think for a lot of the patients that we see that come with prior advice that this may be inoperable, what we really realize is that the tumor is not inoperable, but it's in a high risk location. And in our experience and in our hands, that risk profile is lower and more acceptable than it might be at a center where they don't see these types of locations that often. Neurosurgery and removing a brain tumor is like any technical specialty in life. The more you do it, the more you see it, the more permutations you've handled, the less there's really any uncertainty. So for us at the Ivy Center and at the Barrow, where we have somewhere around 1,300 brain tumor operations a year, and we're the busiest brain tumor center in the country, it's really rare for us to see anything that hasn't been dealt with before.
Mm-hmm. And so, many patients come in, and I think the question is like, why? Why did this happen, or what happened, or, so I think the question then becomes, are there any genetic factors, or is there a why behind why brain tumors emerge?
Yeah, the why aspect is the toughest to deal with because it seems so unfair for any patient. Brain tumors, especially primary brain tumors that arise from the brain tissue itself, like gliomas, the most common of which is glioblastoma, which is an aggressive brain cancer. These tumors arise spontaneously. They're not a consequence of any sort of environmental factors or life choices. They're not a consequence of inheritable genetics 99% of the time. And they often happen early in life, and these patients are often healthy and have no other major issues. So when you put all that together, it's extremely unfair when it happens. It makes you ask, what could have been done to prevent it? And the answer is nothing could have been done to prevent it.
Mm-hmm. So you just mentioned glioblastoma. We know that glioblastoma is one of the most common forms of malignant brain cancer that patients are diagnosed with. And so for our patients that are listening who, have just been diagnosed, what advice would you give to them for patients that are experiencing this diagnosis?
So the first thing is don't panic. There's no generalizing with these tumors. Even if you have a glioblastoma, the glioblastoma from one patient to another is not the same, and how the tumor responds to therapy is not the same. So focus on your situation. Don't spend too much time collecting other people's experiences. The second is, start to work the problem. Identify specialists that you can trust, people that you feel like you can have a good relationship with, people that have seen this before, physicians, surgeons, oncologists that do this for a living and only treat brain tumor patients. That's a good first step. And then, as the treatment for most brain tumors like glioblastoma is surgery, followed by a combination of medical therapy and radiation therapy. And so, this is a marathon, not a sprint. We have to go through this one step at a time, and you have to focus on each of those steps with the blinders on.
So for the patients that have been diagnosed, I think a lot of caregivers and families are always waiting for the other shoe to drop. They're always expecting a recurrence, or they experience scan anxiety every 2 months when they're going through a scan. Can you talk about how likely it is for a glioblastoma to reoccur? And then are there any factors that contribute to a recurrence?
So in general, we have to expect glioblastomas to recur. In general, Glioblastomas are part of a category of primary brain tumor called gliomas. We grade gliomas 1, 2, 3, and 4. Grades 2 through 4 are really what happens in adults. Grade 1 tumors can be considered benign, but really happen in the pediatric population more than anything. Anything after grade 1 is a tumor that is likely incurable with surgery and therefore needs to be watched very vigilantly. And so in all those cases, glioblastoma included, you have to plan for the recurrence. And that's what we do. It's chess, not checkers with these things. So the anticipation of that, though, is really cruel and unfair for patients. And, as you know, my patients have my cell phone number, and I get texts every day from them as they're about to get into the scanner, or I just got one of someone that just came out of the scanner in Texas. And, you just have to kind of steel your mind a bit. I always try to just give them positive encouragement, think positively, get through the scan and move on. And, the more negative scans you have, the more likely it is that it'll stay that way.
Yeah. So, considering that this is a really devastating disease and, the prognosis isn't a good one, how do you find a balance between being realistic and optimistic?
So most patients with these diagnoses like glioblastoma, they're pretty well informed. It's not difficult to get information on the internet or from friends and family. These are rare diagnoses, so when someone has it, there's a ripple effect in the community and everybody becomes aware of it and is trying to help. So in my experience, there's not a great deal of need to ground someone in this situation. They usually come to you already very aware of what they're facing and typically in some form of depression and anxiety. So I think our role really is to empower patients so that they're better equipped to deal with this. And that means you have to inject some optimism. You have to counsel patients that, in fact, there are exceptions. You have to inform patients that what happened to someone that they read about or met doesn't mean that that's how their tumor is going to behave. These tumors are very, what we call heterogeneous. The biology of one glioblastoma to another is vastly different. So that means that you can't write it off as a fait accompli of what's going to happen and when it's going to happen. And I think when we have those kinds of conversations with patients, and at the same time, you roll up your sleeves, you sit next to them shoulder to shoulder, and you're like, look, we're in this together, okay? You're going through it. I'm here with you. There's a whole team behind us. We're going to work this problem. I think it injects a little bit of, optimism and hope. And as you know, that hope is, essential to get through everything.
I think it's pretty well known that you're one of the busiest neurosurgeons in the country. And you're also the director of the largest phase 0 clinical trials program in the world. So how do you make these patients feel like they're part of a care process rather than just a statistic?
I think in medicine in general, it's not one size fits all. So you have to understand who you're treating and what they're about. Different people have different personalities and they respond to different approaches. So for me, for every patient, it's trying to read them, understand their context, and then communicate with them in the way that makes them feel like you're hearing them. A lot of times in medicine, there's a sense of sort of a conveyor belt mentality within it that's a function in part of the pressures that are placed on physicians and the healthcare system. But I think the way you get around that is you just find these little moments where it's just one human talking to another. And when you get into that little space, I think that they realize that, look, you're opening yourself up to them. They can open themselves up to you. There's a vulnerability there and a solidarity. So I try to build that, and it's a different formula for every patient.
So can you talk about some of the challenges that come with treating brain tumors in general?
Sure. So, the prognosis for brain tumor patients with malignant disease like glioblastoma hasn't changed much in decades. And the reason for that is because the tumor itself is very resilient, because it's in the brain and it's hard to get drugs into the brain, and because the tumor has adaptation mechanisms that we don't fully understand. So while we're very aggressive with treating brain tumors, they're also very aggressive in resisting. That cat and mouse game is perpetually frustrating. And I think when you're in this field, you have to have some personal resilience with loss, because you're constantly facing it, and you have to be able to, in a sense, recover yourself, reassemble yourself, and then fight the next fight. So hitting that kind of up and down tempo can be difficult. I think I see that with a lot of my colleague physicians that face burnout. I see that with people within the Ivy Center that are just overwhelmed with the challenges and the losses that we face. So these are part and parcel with the territory that we occupy. This is a responsibility that we have. This is why our patients appreciate us. So we wear it with a badge of honor, but it's certainly, part of the weight that we carry in this space.
How do you combat, you mentioned this resilience that you have, right? Like what gets you there?
Well, first of all, I mean, for me, the resilience are the patients and their families. I mean, it is one thing to be trying to help someone in this situation. It's another thing to be in the situation. And I'm constantly amazed by the resilience of people going through this, patients, caregivers, loved ones. There's just no actually putting yourself into that situation. You're either in it or you're not. So you have to derive some inspiration from that. And frankly, you have to derive a little bit of a sense of obligation. If they're keeping themselves together, then you got to do it too.
Yeah.
Right? For me personally, I think endurance in the field has to do with seeing light at the end of the tunnel. I wouldn't be doing this if I didn't think that there was a solution. And knowing that there's a solution and believing that you're going to arrive at it sooner rather than later is what pushes you forward with more and more force.
So, you talk about a solution. How does the Ivy Center's clinical trials play into this solution that you're talking about? A lot of the patients and caregivers were familiar with the standard of care. We know it's going to be surgery, radiation, temozolomide. But how is the Ivy Center playing into this solution?
So cancer care has changed over the last few decades for everyone except brain tumor patients. New drugs have been developed. Previously incurable diseases are now curable or manageable. You need to look no further than some varieties of melanoma, breast cancer, lung cancer to see the progress. Drug development itself is the key here. There's only so far surgical advances can take you, and we're hitting that plateau. Radiation as well is a function of technology, and that technology has matured to a certain extent. So it's really about finding new drugs for patients that are more effective and less toxic. What the Ivy Center does is it levels the playing field a little bit so that that kind of drug development can happen, because this kind of drug development doesn't happen in a university or medical center. It happens in the biopharma biotech industry. These are private or shareholder-held for-profit entities that really govern their decision-making by financial opportunity. So in part, the Ivy Center was born out of the realization that we have to make this a more palatable risk for these companies to invest their agents into. So when we enter a relationship with a company with an intriguing drug, we tell them, look, we'll pay for the cost of this clinical trial. You don't need to pay us anything. We'll give you all of the data rights to our work. We'll give you all of the intellectual property to our work. And all you have to do is allow us to use your drug, and we'll take all the regulatory risk for you. Now, that's the first step. The second thing we do at a technical level is we do the clinical trials differently than most centers. We do what are called phase 0 clinical trials, which involve giving patients a small exposure, maybe 1 pill or 2 pills of a drug before their planned operation. And then when that tumor is removed, we test that tumor to see whether or not that drug is working. Is the drug getting there? Is it hitting its genetic targets? How well is it doing it? And we figure all that out within a few days of surgery, so that by the time a patient might be seeing me in clinic to check on their incision, we know whether this drug has potential for them. And if it does, then we can confidently tell them, look, we're going to treat you with this new drug because we have some direct evidence in your tumor that this is working. And if it's not working for them, we know that as well. And that information is just as valuable. Now, for companies, this information that I described is gold because we're telling them, this is how well your drug penetrates the brain. Mm-hmm. This is how well your drug hits targets in a brain tumor. And if it's not doing it well, that's also valuable for companies so they can shut that asset down and move on to other indications. So we do all this so that companies with innovative new agents come to us first to test things in brain tumors, as opposed to how it's been historically where we're the last ones in line.
So is there rationale behind which patients are getting to test which drugs?
Yes. So drugs today are not chemotherapies in the conventional sense. Mm-hmm. They're more often than not targeted inhibitors or molecules that are designed for certain type of tumor genetics, certain type of tumor targets. So there's a lot of genetic and target testing that happens for any patient's tumor when they come to the Ivy Center and to these phase 0 trials so that we match them to what makes sense biologically. This is also important because we want to be agnostic about what we're testing. It's not about whether I have a funny feeling that this immunotherapy is really going to work or this, CAR T therapy or targeted therapy is really promising. Those are very, very non-scientific qualifications. What we want to know is there a mechanistic relationship between the drug we're using and this patient's tumor? And that's how we match them up.
So if the drug is penetrating the tumor and doing what it's intended to do, and you see that in the phase 0 portion, how does a patient continue on?
Exactly. So the phase 0 portion is the first half of the trial where we test whether the drug is doing what it's supposed to do, as you said. Then there's a second half of the trial where the patients graduate to a phase 1 or a phase 2 study design, which really means they're getting the drug long term. Mm-hmm. And they continue to get that drug as long as that tumor is under control. If the tumor breaks free of that drug's mechanism and recurs, then we're back to where we started and we try a different agent and we go on to a different protocol. So it's all about showing these tumors different looks. Mm-hmm. Tumors are adaptive in the brain, and glioblastoma especially. So we're under no illusion that it's going to be one regimen or 2 regimens that can give you long-term solutions. It's going to have to be what we call a polypharmacy type approach. I
think a lot of patients that are newly diagnosed are going to wonder why they should take this option rather than an approved therapy like temozolomide. Mm-hmm. So the question is, what do you normally say when it comes to the misconceptions about clinical trials?
Yeah. So the first thing we always say is, when there's evidence for standard of care, that's what should be done. Mm-hmm. Standard of care, as you mentioned, for newly diagnosed glioblastoma is radiation plus temozolomide after surgery, and sometimes with the electromagnetic cap Optune. But there's an asterisk to that, and that asterisk is that for 60% of newly diagnosed glioblastoma patients, they're not sensitive to temozolomide because they have a version of it, of the glioblastoma called MGMT unmethylated tumor. And MGMT unmethylated tumors are a special subtype that represents the majority of the tumors, unfortunately, where temozolomide doesn't have a statistically significant benefit. So for those patients, we think clinical trials are as good or better of an option, because here you have a standard of care drug with limited to no efficacy, and then you have an experimental agent that may have something well beyond that. So for us, that's a particularly vulnerable population. Today in the United States, if you have a glioblastoma and you're newly diagnosed, you're going to get temozolomide because there's nothing else available. But for more than half of those patients, that drug may not have any effect.
So what current research at the Ivy Center are you seeing that is really evoking some excitement. What are you most excited about at the Ivy Center?
Well, I'm often asked by patients and families, like, what's the most promising new therapy? And, the first thing I tell them is, look, if we knew what was going to work, it wouldn't be experimental, and there wouldn't be any question, either from myself or anyone else in the field. We're all aware of each other's data and different centers and programs. As soon as there's anything of promise, everybody sees that data. So experimental therapies are experimental for a reason. We simply don't know how well they'll work. I think what we're excited about at the Ivy Center is being able to push the boundaries of the types of experimental therapies being deployed. There are entire classes of new drugs, meaning kind of new technologies for drugs that have been developed in the last 10 years, last 5 years, last 15 months for other cancer types that brain tumor patients have never tried. And it's not because they're not promising. It's just simply because these companies and sections of industry just haven't put brain tumor patients and their tumors at the top of the list of what to test. They're going for larger markets, like some of the cancers I mentioned. And so we're excited about the fact that we have access to these new classes of agents that other centers just haven't been able to test yet. I think that's an incredible value for our patients. And, your opportunity to discover something new is always optimized when you're in uncharted territory. So that's where we live, in uncharted waters at the Ivy Center.
So, patients that are going through this and families, what would you encourage them, or why would you encourage them to come to the Ivy Center? Is it to have these experimental therapies? Is it because we're a large volume center? Is it all of the above?
What I often tell patients and families is that when you're dealing with something where there's no known cure, multiple opinions is always better than one. At the very least, you're going to get a different perspective, or it's going to stimulate you to think about things a little bit differently. You may stay the course with whatever the original plan was, but getting other opinions and having another set of eyes on your issue can only help you. So we see a lot of patients that are coming to us for second opinions, third opinions, out-of-state patients, international patients coming from everywhere. And, in all cases, what we try to do is we say, look, here are some options that maybe aren't available to you where you are, or maybe you haven't considered. Let's talk through them. It's not just about experimental therapies, of course. As you mentioned, we're a really high volume center. Brain tumor operations are a daily occurrence. When you're dealing with something as sensitive as brain surgery, you really want it to be at a place where it's a routine occurrence. So, I think for the Ivy Center, that's what we see.
I know we've talked about this before, that you've never doubted that you wanted to be a neurosurgeon. What initially drew you to specialize in neurosurgical oncology?
So, my mother's sister had a glioblastoma. Growing up, I saw her go through that and pass away. And I also saw her care team. And I remember her neurosurgeon, who was probably the most stabilizing force in the whole equation. His name was Dr. Stern, Eugene Stern at UCLA. And I think when you're a kid and you don't fully understand all of the technicalities of the situation, but you emotionally feel the anxiety and uncertainty and instability of the moment, it's easy to recognize who's bringing balance to that. Mm-hmm. And I could see it was him. Ultimately, he couldn't solve her problem, and she passed away. But that was really the spark for me to understand how a neurosurgeon can help a family in that situation, even if they can't cure the situation.
Yeah.
And so after that interest then collided with my interest in neuroscience, my fascination with brain biology. And the convergence of those things made me look at it more seriously. And then, like anything in life, you encounter mentors in your career. For me, when I went to medical school at UCSF, it was Dr. Mitch Berger, who was the chair of neurosurgery there, and I think instantly I recognized in what he was doing what I would like to do.
I don't know if I've ever said this to you, but so for all of our listeners that are listening, my mom was diagnosed 2 years ago, and that was 4 years after I started working at the Ivy Center, and you were that to our family. I don't think it's lost on my family or I that, you were this stabilizing force for us. I would trust you with my life, and that's why I picked you for my mom. But, you really made our experience just, I would pick you every day and twice on Sundays. There's not enough words that I could say to talk about how much I appreciate everything that you did. And we could have gone anywhere, and I would choose you every single time.
Well, it's humbling to hear that, and I thank you, and it means a lot, and I know how much you suffered going through that, and how proud she was of you. And, I think that what I didn't quite realize when I entered this field is that that's exactly what I've tried to prepare myself for, to be that person. But it's not enough, because your mom should still be here. And, there's a sense of falling short that comes with that territory that I really want to stop. So, I'm always here for you and your family. And it was an honor to treat your mom. I think that my hope is that in the future, in the very near future, there won't have to be other daughters that convey that to their neurosurgeons. Yeah.
Well, I do think that you were one of the greatest gifts that happened to my family. And the Ivy Center was one of the greatest things. I think it was just destiny that I ran into you.
I agree with the destiny part.
Our paths crossed.
We were fortunate to have you join when you did, and you've been with us since the beginning. And you've been an inspiration in how you've handled this. So a lot of the credit goes to you, Michelle, not to me. I think your mom would have agreed with that.
Okay. So, last question. So we hear the expression, one day at a time, really often. A lot of our patients say one day at a time. The physicians that they run into constantly say, take it one day at a time, one breath at a time, 1 minute, 1 second. So to wrap up the episode, we'd like to do a quick fire of one thing or idea or choice that holds significance to you. So I'm going to read quick fire of questions.
Yeah. Go.
Here we go. What's one piece of advice you would give to your younger self?
I would say it's going to be okay.
What's one thing people would be surprised to learn about you?
I'm a huge supporter of the Surfrider Foundation.
What's one thing you do to de-stress?
Play tennis.
One habit you'd like to break?
Have a longer attention span.
One book you'd recommend everyone reads?
Just one?
Mm-hmm.
Endless Frontier.
One thing you're most proud of?
My daughter.
One profession you'd want to try?
Obviously, professional tennis player.
What's one thing you'd like to be remembered for?
Curing glioblastoma.
Okay, I think that's all my questions. Dr. Sanai, thank you so much for joining us on Brain Tumor Talk. I think it was extremely informative for all of our patients and caregivers who are listening.
Well, thank you, Michelle. Honor to be here, and you're doing an amazing job narrating this.
We hope this episode has informed and inspired you. Subscribe to Brain Tumor Talk so you don't miss another episode, and please consider leaving us a review to help others in the brain tumor community find us.